Okay, so once again, I want to thank Dr. Coleman and the organizers and the technical support who have now finally managed to load my slides to be able to talk to you about whether prognostic tools offer any value in managing patients with Hodgkin lymphoma. So our goal in Hodgkin lymphoma is really a bipartite goal. For our low-risk patients, it's to maximize cure while minimizing toxicity. But for our advanced stage patients, it's to be able to identify the patients who are at the highest risk so that we can escalate or use targeted therapy for this population because we know that standard therapy is not curing enough of these patients. For relapse patients, we want to target intensity to the degree of curability. So we really want to improve outcome across the board from the earliest stage to the relapse patients. Improved prognostic models in Hodgkin lymphoma are vitally needed and will facilitate tailoring of therapeutic intensity to risk, stratification of therapy based on risk assessment, and concurrent adaptation of biologically relevant treatment platforms and biomarker strategies. Hodgkin lymphoma, just as a background, I think it's important to know that Hodgkin lymphoma really has a unique biology. So unlike most lymphomas or solid tumors, where you see sheets of tumor cells that are very much all alike, in Hodgkin lymphoma, the tumor cells, which are the Hodgkin-Reed-Sternberg cells, which are less than 1% of the total tumor volume, are subsisting in a network of immune cells such as T cells, B cells, dendritic cells, plasma cells, and macrophages. And all of these cells of the immune system together cooperating with the HRS cells are what create the tumor in Hodgkin lymphoma. And these immune cells are what the interaction of the immune cells and the Hodgkin lymphoma provide the growth and survival signals that allow the Hodgkin lymphoma cells to evade immune detection. So we really need to understand either clinically or biologically what it is that makes Hodgkin lymphoma either good risk or poor risk. Before we go into specific biomarkers in Hodgkin lymphoma, I think it's worth unpacking the difference between a prognostic and a predictive biomarker. So a prognostic biomarker provides information about the patient's overall cancer outcome, regardless of therapy. And a predictive biomarker gives information about the effect of a therapeutic intervention. So these are very different things. And they're both very important in Hodgkin lymphoma, and they're both worthwhile goals. Putting prognostic tools in context in Hodgkin lymphoma, I'll talk to you today about prognostic tools in upfront treatment. That's really risk stratifying patients. And we'll talk both about clinical prognostic scores and biologic models. We'll then talk about predictive tools to guide interim treatment planning, particularly FDG-PET. And finally, prognostic tools in the relapse setting. I'll talk to you about 2 different relapse scores. So the International Prognostic Score was constructed from over 5,000 patients with advanced stage Hodgkin lymphoma in the 1980s, who were treated in the 1980s, and uses 7 risk factors to risk stratify patients with advanced Hodgkin lymphoma. And these risk scores are age, greater than 45, anemia, stage 4 disease, leukocytosis, lymphopenia, albumin, and male sex. And the IPS-7 predicts a 5-year freedom from progression of 42 to 84%, and an overall survival ranging from 56 to 89% for patients with advanced Hodgkin lymphoma. In this group of patients, approximately 2/3 were treated with ABVD and 1/3 were treated with MOP chemotherapy. So Mochia and others have asked the question of whether in the modern era, when all patients are treated with ABVD or higher intensity regimens such as BIACOP, the IPS-7 still holds in the modern era. And interestingly, what the group from BCC found is that while the IPS-7 still holds in the modern era, the curves have significantly narrowed so that there is much less, so that this is much less prognostically useful, or much less predictive than the IPS-7 was in the era that it was constructed. And you can see really that there is a separation from the earliest stage curves to the more advanced stage patients. I'll see if I can find the light. So you can see really that patients with low-risk disease and patients with high-risk disease separate, but there's really no separation from the first 3 or 4 and the last 2. And overall survival, there's really no separation except for the very poorest risk. So if the IPS-7 has narrowed, are all the components still meaningful? We asked the question in patients who were treated in the modern era from 1996 to 2006, who were randomized to either ABVD or Stanford 5 with no difference in outcome, whether the IPS-7 still held and which variables of the IPS-7 were most relevant. And we found that the risk factors were very balanced between the two arms. And we came up with a new prognostic score based on the 3 factors that we found were both significant in univariate and multivariate analysis. And they were age, stage, and hemoglobin. And so we came up with a score that we called the IPS-3, based on whether you had 1, 0, 1, 2, or 3 of these risk scores. We then compared the IPS-3 to the IPS-7 for both PFS, and you have the IPS-7 here on the left and the IPS-3 here in column B, and for overall survival as well. And we looked at a statistical measure called the time-dependent AUC, which basically is a question of which one is so IPS-3, you want to see which one is closer to 1, so further from the line, and the IPS-3 outranked the IPS-7 for both PFS and OS. And we then looked at reclassification, and this is just patients who were classified as intermediate. You take the way a patient did, so were they high risk or low risk, and you take their outcome, and you see which score classifies them more accurately with their clinical outcome. And for all but the very few highest risk patients, the IPS-3 outperformed the IPS-7. So this was one study. The IPS-3 still needs to be validated in other large studies, but the potential advantages of the IPS-3 over the IPS-7 is that it was streamlined. It only needs 3 factors rather than 7. It may more accurately predict and stratify risk, and it's a potential foundation for a platform of new clinical and biologic factors that could be grafted onto these very easy-to-obtain clinical factors. So the promise of biologic biomarkers, which is, I think, what everyone is most excited about, clinical risk factors such as age, stage, and hemoglobin are by definition nonspecific. And specific biological characteristics of the HRS cells may themselves be more informative than something as generic as anemia or your age. Identification of factors unique to malignant cells may also provide specific and differential targets for therapeutic intervention. So this would be a 1-2 punch. If we could find biological factors that predicted poor outcome, we could then potentially target them and obviate that poor outcome, similar to Herceptin in breast cancer, for example. The limitation of biologic biomarkers. There is, to date, not a wide validation of their significance across multiple trials. Many are demonstrated only in small series. They're not reproducibly shown to be significant in multiple independent series of patients. And many of these biomarkers are themselves not independent. They travel together often, such that elevated levels or expressions of one is often associated with elevation of several others. And here's a table of a whole panel of different biologic risk factors that have been shown to be predictive in different studies. And the ones that I've highlighted in red, so tumor-associated macrophages, serum TARC level, serum galactin-1 elevated, IL-10 and IL-10 or IL-10 receptor. These are the ones that have been highlighted in red have been validated in more than one study and are further along than most of the other ones. But you can see that there's really a range of different biologic risk factors. There are some risk factors that are associated with Hodgkin-Reed-Sternberg cells. There are risk factors that are associated with the microenvironment or circulating non-malignant cells, the circulating immune cells, cytokines. There are some gene expression and mRNA profiling, and there's some host germline polymorphisms as well. So the list is long, and it will be an exciting time in Hodgkin lymphoma to parse together which ones of these are the most relevant and the most prognostic. But we're going to need large prospective trials to really answer these questions. This is a slide from the Steidl group at BCC, really looking at what you would do to try to do gene expression profiling or to use a molecular microscope approach to try to come up with a prognostic score. So to look at HRS cells, T cell subsets, and B cells and macrophages as sort of factors of these that would predict poor outcome, and then other factors of these that would predict good outcome, and try to score between these. So what is really the most significant to date is intra-tumoral macrophages, CD68 positive macrophages, both on IHC and on histology, have been shown that so overexpression of CD8 positive and CD163 positive macrophages is predictive of a poorer outcome in upfront Hodgkin lymphoma. We'll now turn to risk stratification during treatment and FDG-PET, So FDG-PET is a tool that can be used to stage patients prior to treatment, but FDG-PET is also being used as a predictive tool to assign therapeutic decision-making during treatment. So there are many studies that have now used FDG-PET to assign patients to escalated or de-escalated therapy. And basically what we can see is in several early phase studies, 80 to 85% of patients who are PET negative, 80 to 85% of early stage patients reach PET negativity after 2 to 3 cycles of therapy. And these patients have a 90% likelihood of remaining free of relapse. So we can safely say for our lowest risk patients that patients with a negative FDG-PET scan after 2 cycles of ABVD are at a low risk of treatment failure, and these would be a group that we could potentially explore de-escalation strategies. For advanced stage patients, negative interim PET is found only in about 80% of patients, and by interim PET, this is a PET scan after 2 cycles of therapy that is a Deauville 3 or lower. A negative PET does appear in this group as well to be strongly predictive of favorable outcome. However, the impact of a positive PET scan in this group is much less clear, and there's a failure-free survival rate for positive PET scan in this group that ranges in different studies from 0 to 40%. This is probably because positive PET scan in this group is not necessarily indicative of residual disease. So in studies where patients with positive PET scan were biopsied and found to be negative for lymphoma, the PET positive biopsy negative patients did almost as well as the PET negative patients. For PET positive patients who are biopsy positive, their outcome is significantly worse. So it really, PET positivity, although PET negativity is strongly predictive, PET positivity is more complicated with regard to interim risk stratification. With regard to a prognostic score post-transplant, the German Hodgkin lymphoma study group came up with a 5-factor post-ASCT clinical prognostic score, and these were the factors that were most significant on multivariate analysis. So these are patients who prior to transplant had stage 4 disease, a time to relapse of less than 3 months, an ECOG performance status of 1 or worse, high bulk, or an inadequate response to salvage therapy. That is, they go into transplant not in a CR. And you can see that the curves very nicely split between having 1 risk factor, 2, 3, or 4. So the other issue with biologic risk prediction at relapse, to move from clinical to biological, the underlying biology of first-line treatment failure is unknown, and there are really currently no good biomarkers to predict the outcome of second-line treatment. Moreover, there may be biologic differences in disease at relapse compared to upfront therapy. So the Steitel group did a trial where they basically biopsied patients at relapse and came up with a relapse predictor score that they call the RHL30. And they basically did a training set and then a validation set of a gene signature of relapse after transplant. And the RHL30 was independent of other biomarkers in pairwise multivariate analysis in a combined validation cohort. The RHL30 will need to be validated prospectively in upfront trials of relapse lymphoma as well, particularly as all the patients on the RHL30 had received ABVD upfront. And it will be very interesting to see as patients are getting more novel therapies up front and the salvage becomes more complicated, whether the RHL30 still holds, but it is an exciting new development. So how risk stratification can guide personalized therapy. So patient is diagnosed, they get staging and prognostic scoring. If they're low risk, they get a short course chemotherapy and proceed to PET-CT. If they're high risk, they get a chemotherapy or clinical trial, they go to PET-CT. Interim PET, if they're PET negative, they complete therapy. If interim PET is positive, they escalate therapy and potentially go on to a clinical trial. And then risk stratification at relapse. So if the patient is, they get their first line treatment, if they relapse, they do an RHL30. If they're considered low risk, you can target your therapy, and most of them are cured. If they're considered high risk, then you consider a clinical trial or further escalation of therapy. So in conclusion, we do have some clues about prognosis in Hodgkin lymphoma, but improved prognostic models are vitally important in Hodgkin lymphoma and should be integrated into prospective randomized trials. Clinical prognostic scores in the modern era continue to need refinement and modification, as well as validation and integration with biologic biomarkers. Promising biologic markers need validation in prospective trials and need to be combined with clinical features to come up with a robust clinical biologic tool. And FDG-PET has strong negative predictive value, but positive predictive value remains uncertain, and novel imaging modalities are being evaluated to try to get around this problem. Thank you very much.